Southeast for whom we are corporate parents together. This event is very much aimed at professionals who are in clinical roles to understand particularly what we're trying to do strategically in relation to children in care and focus together on the clinical practice guide that Dr. Gavin Lockhart and colleagues from the Anna Freud Centre have written for us in the Southeast, but has been then disseminated nationally. We're trying to create a sense of community here as much as we can together. So there's a real chance to kind of talk together and ask questions and provide a little bit of space for reflection. Some of you will know that we had a previous event a few weeks ago, and that was in partnership with our social care leaders. We had 130 different leaders from our social care services representing every local authority in attendance with us. Also talking about how we could use this clinical evidence to further improve outcomes for children in care, specifically around their emotional and mental health and well-being. That was an amazing event, and you'll have access to all of the materials that we've produced in the Southeast. Gavin, thank you for sharing that. Today we're going to focus particularly on the clinical guide. If you feel like maybe you're not in quite the right conversation, so you weren't as interested in a clinical conversation, please don't feel like you need to stay with us. There is a further conversation that's happening in a few weeks' time, which is aimed at CCG commissioners particularly and managers within provider services. So that may feel like a more appropriate conversation for you. But if you want to stay and listen, you're most welcome. Good. We are recording this session. Any concerns, please indicate that in the chat. We'll make this recording available and that will then enable you to share and disseminate this across the Southeast in each of our provider trusts and our wider partnership arrangements. So,
hi, Andrea.
I think we're there. Hello. It's so
I am so sorry. I don't know why I didn't have an invite. Hi, Gavin. I just got it.
Wonderful. Please don't say sorry. We're so pleased to see you. So we were just doing a little bit of context setting while we waited for you to join us. Thank you so much. Anna Maria, what we'll do is we'll move to the agenda slide, and in a second I'm going to welcome formally Dr. Geetha, who's joined us from NAF. We're so pleased to see you, and thank you so much for being our clinical sponsor for this event. It's just lovely to have you with us. If I can just do a little bit of basic housekeeping, which is bandwidth tends to be a little bit of an issue for us when we've got this many people joining on Teams. So you may wish to go off camera when you're listening and then just come back onto camera when we start talking together. Please could everybody just put themselves on mute, because that's really helpful in terms of managing background noise as well. And we are recording this session, so that noise will be picked up in the recording. Thank you. It's my real pleasure to welcome everybody here today to focus on our children in care and our shared responsibilities towards them and improving their emotional mental health service experience. I'd like to hand over to Geetha now, who's our Associate Medical Director from NAUFT, who's going to provide that clinical welcome to everybody gathered here today.
Thank you, Andrea, and thank you, Gavin. I really I feel honoured and also pleased about Jihad's absence, because I had this opportunity because he wasn't available. This is something really close to my heart, and I welcome everybody who has kind of made time to attend this. And I have myself read the final guide, which was absolutely, I felt like I was reliving my experience, day-to-day clinical experience, and it's fantastic. I know, Andrea, you've just given the basic housekeeping, but I just wanted to let people know it would be helpful if you can put your phones on silent. I'm sure a lot of you will be on call and you might have to take certain calls, but it'll be nice and helpful if you can put them on silent. And also to let people know that you can type your questions in the chat box, and Andrea and Gavin will keep a check on that. As we go along, you can ask any relevant questions to the presentation. I mean, again, it's up to you. Andrea and Gavin, would you like people to type in as we go along, or would you like to have, yeah, that's okay. And I think you've already informed the attendees that there will be another session in July. and people can choose which one would be more appropriate for them. And also, I would really advise people to look at this guide in collaboration with the up-to-date NICE guidelines for children in care. That's in the draft format now. That would make more sense. Right, so that's me. And shall we just go around with some introductions of the attendees?
So I think we might struggle with the number of people we've got here to introduce everyone.
Okay,
if people would like to indicate your attendance in the chat, so it's a lovely way to say who you are and where you're from in the chat. Well, we really welcome that.
Oh, that's great, Andrea. I wasn't aware of how many were attending today. Yeah, that makes sense. People can just pop in your names, which agency or organization you're from in the chat box. That would be really, really helpful. So I don't know if there's anything else I have missed out, Andrea.
No, that's wonderful, Geetha. Thank you so much. And I'm sure that we'll be drawing on your expertise throughout the conversation today as we think clinically then, what's the applicability of this? You made a really important point about the NICE guidelines and the new consultation that's out. And Gavin has done an excellent piece of cross-matching our clinical guide to the proposed NICE guidelines, and the read across is so coherent. Colleagues, if you're interested in the response we've submitted in that respect, please do just let us know. We're very, very happy to share that. And we're particularly grateful to the role that Nancy Sayer, who I think is amongst us, I've seen Nancy at the start, has played in terms of providing an interface into the committee that's working on this on the behalf of NICE. So thank you particularly, Nancy. Right, I can see all of the reflections of just how many people have joined us across the South East and the good spread we've got. So thank you so much. That's marvellous. What we'll do then is we'll get underway with a bit of the content. You'll receive all of these slides, everyone. We've got the link attached to the website that includes all the documentation, including the clinical guide that we'll be talking about at length today. Gavin, would you just like to say hi to everybody before we move to the first presentation so everyone knows who you are and what you do?
Hello everyone, I think I know some people on the call and not others, so I'm Gavin Lockhart. I'm clinical lead for children and young people's mental health with both NHS England and Health Education England across the South East, and also work at the University of Sussex. So I'll say a little bit more about my background and how it's relevant to children in care a bit later on. But it's good to see everyone.
Thank you, Gavin. That's brilliant. So Gavin is the brains and the energy behind writing the clinical guide in partnership with Anna Freud Centre colleagues and Cork. So we owe much of our thanks today to Gavin. Okay, what we'll do is we'll move on to the first presentation slide, please, Anna Maria. So by way of introduction to anybody I haven't met before, I'm Andrea King and I'm the Assistant Director of Children's Mental Health Old Money, Tiers 1 to 3. Across the South East region on behalf of NHS EI. And many of you will know I spent 20 years in local authority leadership before coming over to NHS EI when the organisation first said, we need some people who can talk local authority. We need some people who can think about the complexity of integration across social care, health and education. So that's where people like me were sourced from. And I suppose it's in work like this that those skill bases come together most effectively. Just going to spend a few minutes talking about the children in care strategic work that the South East region has led on behalf of the country. So first thing to say is be proud that what you have actively contributed to as providers, as commissioners, as local authority leaders, education, health and voluntary sector. We've really seen the impact not just for us as a region but for the country as well, who have now followed our lead and are adopting our arrangements. This started in week 1 of lockdown with a couple of our children in care who were placed at the opposite end of the country to the South East, and for the first time were actively denied any access to mental health support, in complete dereliction really of our shared statutory responsibilities for children. We are shared corporate parents for these children. And what we found, because of the pressure that our services found themselves under quite early in the first COVID lockdown, was a complete denial of some services to some of our children in the other end of the country. We followed every child through until they got what they needed. But I think it led us to a point where we were saying these rumbling problems we've had around children in care for a long, long time, between health and social care, across our mental health access. We've got to do something more strategic and systematic about that. So it started with the voice of our children, and experts by experience, children in care and care leavers have journeyed with us the whole way. Over the last year, we engaged all 19 directors of children's services, have sat with every designated nurse and most of our dons, our provider leaders, our voluntary sector leaders, our virtual vets and children themselves to say, what is it we could do that's achievable and realistic? Some of you will have seen the analysis we conducted in partnership with CESLIP. So this was CESLIP's first work on saying, what do our children in care need, and what are their primary characteristics? How much does it cost us to be able to meet the needs of children in care? 800 children were analysed, and you'll see the average cost for a child was 2.4 million just from local authority budgets alone per week. 2.4 million a week just from local authority budgets. And you'll see there the figures of those children based on that very kind of first calculation who were demonstrating emotional and mental health needs or learning LDA needs, or particularly autism and ADHD. So we got a first picture, but we knew it wasn't enough. What we agreed with our ICS leaders and our directors of children's services and lead members was that we would devise a project that was of 2 phases. Phase 1 we completed in December 2020. And phase 2 we started embarking on in January. Phase 1 applies to everyone. Phase 2 applies to some people. Next slide, please, Anna Maria. This is the number of children in care that we had in 1920. So we've got just over 10,000 children in care in the South East. Let's be clear. These children become children in care because they're not safe, because their needs can't be met. They are the children who have experienced the most adversity and trauma of all the children that we work with. It is our presumption that there will always be an emotional health support need they will have, and many will have additional mental health needs. The number of children in care we actually find in our CAMS services is far less than we would expect to find. And having sat with many of our children in care across the South East, what they often describe is, it's really hard to get the help I need with how I'm feeling. It's really hard for me to trust somebody with what I've lived. Being in a hospital environment's really challenging. So those are some of the questions we started to try and unpick, and this gives you a few figures if this is helpful to you. You've got the average cost there, and there's a bit of profile information here for us in the South East. We generally have less children coming into care as new entrants than many of the other regions that we're compared with. We do have specific numbers of unaccompanied asylum-seeking children, and if you're sat in Kent and Medway, if you're sat in Portsmouth, you will be feeling the pressure of that, very real pressure of that. And we know that the most recent action Kent has taken in relation to the Home Office. It's not an evenly distributed number of children across the South East. There is more we might do together around that. What we do see in the South East is a high number of adolescents coming into care. And that's something really important for us as clinicians and as commissioners, because what that tells us is actually we've got quite a number of these children going on to become care leavers. And what our care leavers tell us is it's often in the mid-20s or early 20s, first baby, first house, first job, whatever it might be, that you have a chance to stop and say, this is what I've lived, and this is the impact it's having on me. And in most of our areas, we really don't have anything bespoke for these care leavers that can meet their needs. Not for everyone, but for most of us. So community mental health transformation is a fantastic opportunity to start to look at that together. We'll come on to that a bit later. Next slide, please, Anna Maria. Thank you. Here's the rate of children in care. So we've seen a surge of between 70 to 107% in children mental health need last year in our services in the South East. We've had the highest surge in the country in the South East, haven't we? Similarly, complex children hitting the social care system has risen. This is what our picture is looking like over time. So actually in London and the South East, we've got a kind of a grip on this, and we're seeking not to be risk averse in the way in which we work together. So it's not a dramatic increase, but it's a marked and consistent increase. And again, that impacts on care leavers as well. So that's our overall picture. Next slide, please, Anna Maria. Here's the US picture. Now, I referenced this earlier. Kent and Portsmouth colleagues are under particular pressure. Kent in particular has a very, very high number of US. And so the distribution of our unaccompanied asylum seeking children who've got a very particular set of experiences, whose emotional health needs then are very specific, is a discrete group in our consideration, and Gavin will refer to that a little bit later in our conversation. Next slide, please. Here were the phases that we agreed. At the end of December, everyone, apart from one ICS area where we're just tying up some loose ends, everyone had a picture of your individual child in care population. If as a clinician or a clinical lead you haven't seen that yet, you're in Kent and you haven't seen Kent, or you're in Sussex and you haven't seen East, West Sussex and Brighton and Hoves, do let us know because we can send that over to you. What it did was said, who are your children in care? How many have you got in your patch? What's working really well for those children? What does our analysis tell us about the emotional mental health needs of those children? What are the gaps in the system, or the bits where it's a bit tricky, based on the feedback of your children, but also of senior leaders, IROs, social care leaders, directors of children's services, providers, clinicians, etc. That's a really, really rich picture. So if you're thinking, I'm not sure I really know how many children in care we've got or what the prevalent needs are for our children in care, it is there for you to use as a tool. We negotiated Pan South East 3 agreements that we signed up to as regional systems leaders. A tariff system which is aimed at CCGs, which was to stop the level of overcharging for children in care emotional mental health support that was happening between regions. So we'd expect an assessment for a children's mental health standard kind of assessment to be in the region of about £280 to £300 generally, and we were being charged in some cases £5,000 for the same assessment in other regions. So that tariff has rolled out nationally to stop the overcharging. That's important because it increases the pot available for the child, and that's where that money needs to go. So just to be aware, that's all happened behind the scenes. We've got a roles and responsibilities document, which is really designed to reduce the number of disputes and then escalations between agencies for children in care. That had been highly successful before we moved into this most recent impact of surge, and we're now starting to see those escalations starting again, so that's there too. Most important of all was an ambition for our children in care. It was a kind of heart and mind's commitment to say, you matter, we are parents to you as professionals. This is our commitment to you around emotional and mental health support. We moderated the language in that. We moderated it deliberately just before we signed it off, because we could see the numbers of children heading into the mental health system. And we knew that whilst our aspiration was children in care would receive a really prompt service always, the reality of what we could deliver was likely to be variable depending on the pressure on our services. So all those documents are there and they're available for you to use, and they've been rolled out nationally. The other regions have adopted them. The clinical guide was part of our phase 2, and we produced that in April. And the next stage really for us was these 2 big conversations. We have 4 areas piloting integrated commissioning of brand new provision for children in care. That's both emotional mental health provision and social care brought together. So a co-commissioning arrangement. We'll talk a little bit about that in a minute, but if you're in Kent, Portsmouth, If you're in West Sussex, you'll be seeing that work happening. Notice it's just gone to providers. We're in mature conversation with providers. That's quite big. And we're just piloting to see how's that going to work. It's big and brave. We're also asking every ICS in community mental health transformation work to really think about care leavers for the reasons I've just described. Can we understand how many care leavers we've got and what their needs are? We've done that work. What then could we provide for them as part of the wider ethos and values of community mental health transformation, which does refer to this group on page 21 of the guidance to say they are a priority for this work. So let's take the next slide, please, Anna Maria. Here are the agreements. If you want to go and see them, please look at them. Please check your staff teams have seen them, particularly the clinical guide, because that was written for you and for social care colleagues as well, and other colleagues working with children in care. But they're all there and available, and we update this regularly. Next slide, please, Anna Maria. The guide has been supported by all of these partners on the right here. So you'll see all of these significant advisors across the country have helped pull this together. And I hope that gives you some confidence in terms of what we have been working to achieve. Again, and Gavin and I have just agreed to do a presentation nationally in July on this, Gavin, haven't we? This has been rolled out by all NHSEI regional teams. It's also been rolled out by the Association of Directors of Children's Services, which is brilliant. Next slide, please, Anna Maria. We've written to every chief executive, and this letter has come from Sam Allen, who's chief exec of Sussex Partnership, and Nick Broughton, who's chief exec of Oxford Health, asking chief executives to help us with these phase 2 developments. The first thing is really thinking about community mental health transformation and making sure that care leavers are considered in terms of the service design and transformation work that you're doing at place now. As clinicians, you'll know what these care leavers best need. We know that we can see our care leavers overrepresented in crisis, in inpatient care, in perinatal, in IAT. I could go on. What could we do? If you want help with that conversation, can you let me know? And between us, with the partnership with James Carter, who leads community transformation, mental health transformation for our team, together we will work to try and support you with that. We've also highlighted this co-commissioning, co-production work with social care providers for the first time to create residential provision for the rising number of children in what I would describe as tier 3.5 plus, for whom there are complexities in their emotional health needs that don't meet a tier 4 criteria, which are related to their social welfare experience. And we need providers that are adequately resourced with both emotional health input and skill and training, and mental health provision, as well as the social welfare expertise. I am so grateful to Vanessa Fowler from Specialist Commissioning for agreeing to put money on the table to help with this process. And our colleagues like Hayden will describe where we are with that in live conversation with providers at the moment. Next slide, please, Anna Maria. If I can just encourage you to think about these preventative points. We've looked through with Directors of Children's Services social care assessments of the children who will become children in care if we can't intervene earlier, or we can't make the difference for families. These are the factors our children live with, and this really helps our clinical practice. So you'll see the rate of domestic abuse, you'll see the rate of parents and carers living with mental health, ill health and needs. You'll see alcohol and drug misuse. You'll see the LDA factors here too. There are many kind of complexities here, but this is the kind of holistic thinking we need in our CAM services. And wherever we've got a bit of a pathway model that says, well, now come on, this is anxiety and depression, it's over here, and then we've got autism or LDA over there, and all kinds of options in between. These children cross most of those demarcations, and what we learn is we don't always serve them very well because of that. So my first question to you is, as clinical leaders, for the commissioners amongst us too, could you do some thinking on this with us? We need a set of services, emotional health services, that see the child in their complexity and that respond to the child in their complexity. That feels like a really important conversation for us to have. Next slide, please, Anna Maria. Here are some of the enablers, strong preventative strategies. I've just highlighted Kent and Portsmouth was particularly strong in this area, but there's others. Oxfordshire could equally be up here. The rapid expansion of more mental health support in schools through MHST, and what we would describe as that kind of whole system response. So those of you who've got family safeguarding models or the equivalent, where we're really starting to bring these complexities together in how we work with families and with children, you'll be very familiar with this. Next slide, please, Anna Maria. This is the evidence, if you need it, if you need it, about the adverse outcomes that many, not all, but many of our care leavers live with. So I just want to be really clear on this. Experience of trauma and adversity is always mitigated by character and protective factors, isn't it? Some of our world leaders, our UK leaders, our systems leaders have had an experience of significant lifelong trauma, have had experience of care. They become our most effective leaders. But many of our care leavers go on to experience really, really challenging lives, really, really challenging adulthoods. And if you want some evidence to make the case within your ICSs, this is a good place to start. Next slide, please, Anna Maria. So these are the questions we would encourage you on the care leaver point to be thinking about. Can you identify care leavers in your inpatient services, in crisis, in perinatal, in IAPT, etc.? How are you considering their needs in community mental health transformation? I've read all the community mental health transformation plans, struggled to find care leavers. So we've got a bit of work to do there. And then what would the volume be and how could we maybe support with data management there? Thank you. Next slide, Anna Maria. So on that point, we're just going to pause. And before I hand over to Gavin to think about the clinical guide, this is just a chance to say, have you got any immediate questions on this wider strategic work? Any points you look at and you think, I'm not sure I understand that, or this has really made me think about this, are most welcome. Please either raise your hand or indicate in the chat. Okay, so you're either stunned or we answered every question really well. Go on, Geetha, go on.
Sorry. Yeah. Right. I just thought, would it be possible to have a bit more information on the co-commissioning?
Yes,
I mean, I'm talking from a practical perspective where we do have within the Children's Mental Health Service, how there is always this battle. Is this young person better cared for in a social care setting or a hospital setting? And sometimes we make decisions just based on the availability rather than the need.
Yeah, exactly right. So this starts that whole conversation again, really, Geetha, and what it tries to do is say, right, what could we put in terms of resourcing to developing new provision that doesn't try and separate mental health and emotional health support from social welfare, but rather integrates them. So we're currently working with our providers to say, what would that look like? How do we build on it and how do we resource? So in terms of resourcing, Directors of Children's Services have very graciously put social welfare resourcing on the table to make this happen. And Vanessa Fowler from Specialist Commissioning is similarly helping in terms of resourcing. So then it's about design. As it's going to take us about, it took us about 4 or 5 months to get the legal agreements to do this. Well, we got them. We think it's going to take us about 6 months to do the design work. So we've just in that first dialogue with providers now. So by the end of this financial year, we'll be quite clear about what's possible, what does that look like? And there's no assumption that what works for Kent is going to work for West Sussex, is going to work for Portsmouth. So these are happening at local level. Once we've got a flavour of that, Geetha, then what we can do is start to roll out the principles of the practice southeast wide, because there are many areas that would really like this kind of approach in their local patch. Does that help?
Yes, it does. And it's very reassuring, to be honest.
Okay, marvellous, thank you. All right. So what we'll do, colleagues, is we'll probably move on then, if that's all right, unless there's anything else anyone I've missed. We'll move on to Gavin's talking through the clinical guide specifically. Gavin, welcome.
Thanks, Andrea. Anna Maria, I'm going to try and run the slides from my end, if that's okay, just because I've added a few animations, so bits come in sequentially.
Yeah, sure, no problem. I'll stop sharing.
Right, I'll just make sure that my emails aren't going to flash up as soon as I screen share. Okay. So hopefully everyone can see. So we've got about 25 minutes just to give you a bit of a, some of you may well have seen the guide, some of you may well have had a chance to read it already, but just to really give you an overview, talk about the context for developing it, some of the content that's in there, and think a little bit about some of the key messages that might be particularly relevant to many of you that are on the call today. Before we went into it, I just wanted to give a bit of context in terms of my own background and my particular interest in this area and around children in care. So I trained, it scared me when I realized this earlier today. I trained 20 years ago. My core training was 20 years ago. And during my core training, one of my specialist placements was in children in care through choice, because it's an area that I was particularly interested in, a group of young people that I felt quite strongly towards in terms of making sure that their needs are best met. For my time as a frontline clinical psychologist, that was in Hampshire CAMHS, and I've seen a few colleagues are on the call today, so it's really nice to see some familiar names popping up there. And in my time in Hampshire CAMHS, through one of the various iterations that I had in Hampshire CAMHS, I worked in a couple of specialist teams that were multi-agency teams, so integrated social care and health with some education input. Really looking to work with families and young people who the mainstream CAMHS team were finding quite difficult to engage in a meaningful way with. And by definition, many of those young people were children on the edge of care or children who were in the care system. And that included working in a secure children's home for a while in Hampshire, which some of you may well be familiar with. So along the way, I've also done a fair amount of training around different approaches to supporting young people in care with their mental health difficulties, including attachment training, video interaction guidance training, training in interpersonal therapy, which has some quite strong attachment origins in there. So it's kind of been a feature throughout my career. So if I just run through what we're going to try to cover over the next 20-25 minutes. So I'll give you a bit of an overview of what the clinical review and practice guide is, and then what the contents are. So what you can expect to find in the guide, and also how that might be used. And then wanted to just pull out some core overarching principles that actually we start the guide off with, because we felt that they were really, really important in terms of an overarching ethos towards thinking about mental health and emotional well-being for children and young people in care. And then to pick out some key messages, and I've particularly I've added a few slides in there from the webinar that we did with independent reviewing officers a few weeks back, because I felt there are some things that are particularly relevant to clinical leads that might be useful just to pull out that are mentioned in the guide. And then as you may have seen in the agenda, we've got some time after the presentation for questions and answers. Please do use the chat bar, and we can monitor any questions that are coming in, and we'll try to respond to as many of those as we can as we go through. So this slide might look familiar. I hadn't copyrighted it, so Andrea also used it in her presentation because it's such a great slide. So just in terms of the initial brief, so Andrea had a conversation. So some of you may have seen in the Southeast, we pulled together a report, a document to try to support people in restoration and recovery planning in children and young people's mental health services in relation to COVID. And on the back of that, Andrea had a conversation with me and said, look, would you be able to work with colleagues to pull together maybe a couple of page summary of evidence-based practice around supporting young people in the care system around the mental health and emotional wellbeing needs? So I said, yeah, that's absolutely fine. The intended audience is in independent reviewing officers. Yeah, no problem at all. Then we started to get into it, and what we discovered quite quickly is that 2 pages really didn't do it justice, and if we wanted it to be something that was useful and practical, then we were going to need to do more than a couple of pages. So Andrea has very kindly reframed that as a maturation of the document. So what you see is the matured version of the document. And the aim of the document really was to focus on recognising, understanding, planning and providing support for mental health and emotional wellbeing needs of our children and young people in care. The document very much tries to draw on evidence-based practice, and I think sometimes evidence-based practice can become reduced just to research evidence. So we were quite keen that we represented that three-legged stool of evidence-based practice, which is absolutely best available, most up-to-date research evidence, but also expert consensus. And some of the expert consensus documents that we've referenced and used include the voice of young people who've experienced care and their caregivers, but also the preferences, wishes and characteristics of the people receiving care, which we know can sometimes be different for young people in care from the population of children not in care. And what we tried to do is collate that information and almost have three purposes to it. So one is just conveying key information. The second is giving some recommendations on best practice. And the third is really giving some practical tips and tools and resources that practitioners across the wider CYP workforce can use. So as Andrea said earlier, we've drawn on a vast array of documents, a vast array of expertise, and really we've tried to collate that. So there isn't too much in the document that's new or our own novel thinking. It's really just a collation of what's already out there and some of the thinking already out there. I think what became apparent as we were developing this was that although it was primarily aimed at independent reviewing officers and social workers, that it was actually going to be something that could be useful across the whole CYP workforce. What we've tried to do within the guide is balance different perspectives, because there are different perspectives out there, and I think we need to be respectful of those and recognise those. So we've tried to balance those perspectives, but with a constant eye on evidence-based practice and best practice, and also an eye on trying as far as we can, where it's appropriate, to none other young people in care. I think sometimes there's a risk that we see them as so different from children who aren't in care that they're not offered the same opportunities in terms of mental health and emotional wellbeing support that their counterparts who aren't in care have access to. So we've tried to come at it through that lens. The other thing that we really have tried to emphasise within the document is that there's a significant amount that people who are not mental health specialists can do by way of exploring, understanding, and supporting mental health and emotional wellbeing needs of children and young people in care. So we've really tried to emphasise that and give some practical tips around that and some assurances around that, so that everything isn't seen as needing specialist mental health provision. We've emphasised the value of consultation, and I'll come back to that in a couple of slides' time. But what we've also tried to do, particularly in relation to attachment and mental health difficulties and neurodevelopmental difficulties, is to pinpoint markers that a young person might require a more specialist assessment or more specialist input. So getting that balance between emphasising what non-mental health specialists can do and provide that can be incredibly impactful, but also when it might need something more. So this is just taken straight from the document. This is what you can expect to see inside the document. So I've already mentioned the first few bits here and that we've got the core overarching principles. Section 1 really is focused on identifying and exploring mental health and emotional wellbeing needs and monitoring progress or outcomes of support. So that section is very much targeted at non-mental health specialists, particularly social workers, maybe designates nurses, doctors, around how they might start to explore and understand children and young people in care's mental health and emotional wellbeing needs. It gives some tips, some very practical tips about starting those conversations and about how you might ask about things such as self-harm or suicide risk. As the clinicians amongst the audience would expect, it talks about combining quantitative and qualitative methods, and it gives some pointers to screening tools for different aspects of mental health and emotional wellbeing that are freely accessible, easy to use and easy to interpret. And it also gives some pointers on areas to be considering or thinking about when reviewing mental health and emotional wellbeing of children in care. So a lot of that will be very familiar to those of you for whom mental health and emotional wellbeing is your bread and butter, for clinicians in the audience. Section 2 then moves on to planning support, and it's broken into 3 sections. So the first part of it really is around building well-being and resilience, and what we've really tried to emphasize in there is that there's a huge amount that can be done, even for young people who need specialist attachment interventions or specialist mental health or neurodevelopmental interventions. There's still a huge amount that can be done around well-being and resilience, identity, belonging, sense of purpose and value in life, that is achievable through people who are already in the young person's life and people who aren't mental health specialists, and that some of those things may negate the need for more specialist interventions, or if they don't, they may well complement and improve the outcomes from those interventions and help sustain the impact and outcomes of some of those interventions. So that's the first element of that section. We then move on to talk about attachment, and then mental health and neurodevelopmental difficulties. So I'll unpick those in a couple of slides' time. All of these have hyperlinks, so it's a really quick to navigate, easy to navigate document. So the document starts off, as I said, with some core overarching principles, which we felt were really important just to get out there at the start and to have that overarching ethos when we're approaching this. So again, I don't think any of this is particularly new or novel, but felt important to have in one place. So really emphasising mental health and emotional well-being of our children and young people in care is everyone's responsibility. Thinking about it, asking about it, exploring it, supporting it. This real ethos of doing with, not doing to, and that felt particularly important to us for children and young people in care who can often feel quite disenfranchised, a lot of decisions made about them that they may not necessarily have any say or sway over. So it also gives some tips in terms of just making sure that we're truly trying to get collaboration in there and not just compliance. Acceptance, curiosity and empathy, that's just about the ethos to the relationship and to the conversations. That's drawing on some of those ideas that some of you may be familiar with from dyadic developmental psychotherapy or other types of therapies. Inclusion, I've already mentioned, that is really around the non-othering and reasonable adjustments and equal access where we can achieve that. Looking beyond behaviour, it does what it says on the tin. The no one size fits all, I just wanted to pick up on that. So within the information giving elements of the document, we have referenced the types of interventions or approaches that have the strongest evidence or the strongest support, but it's very rare that there's just one approach for a particular difficulty that the young person in care might be experiencing in terms of their mental health and emotional well-being. So we've put the options in there so that there's that flexibility inbuilt. Okay, so here's some of the key messages, and again, I'm sure some of these will probably be very familiar to many of you on the call. So the first thing is around mental health and emotional well-being not being disconnected from that wider holistic understanding of the child or young person's life and needs, and really recognising that the two are intrinsically linked and can mutually influence one another. The second, as I've already hinted at from the contents page that we had a couple of slides back, is that health, well-being and resilience is absolutely at the core, but can be really overlooked and downplayed. But the evidence is that can be some of the most engaging and successful support that we can get in place for children and young people in care. This third point, again, it's emphasised in the principles, is around and it absolutely makes sense when you think about what may have led to these young people being in the care system, is that there's been some disruption along the way to those relationships with the adults around them and the people they rely on to look after them. So it absolutely makes sense that some of the most effective support and impactful support comes from the adults already in their life, or through those outside of mental health, specialist mental health settings. But we have emphasised that there's a strong evidence base for consultation, and I think this is something that we really tried to pick out in our webinar with independent reviewing officers. I think sometimes there's a sense that consultation is a fob off and is somehow lesser than one-to-one support. So we've really emphasised in the document there's a really good evidence base for consultation, and it's often the most effective thing that a mental health specialist or a looked after children or attachment specialist can offer. It's interesting that the draft NICE guidelines, one of the newest things in it that I noticed when I was going through is there's a suggestion that for children and young people in care who are awaiting CAMHS input, that there's an outreach service offer. So it isn't a replication of what they would be getting once they're in CAMHS, but it's outreach support whilst they're awaiting, which I think kind of fits with this consultation offer as well. We've tried to pull out, although it's well intentioned, that not all young people in care need therapy as a result of their past or present experiences, but that being in care doesn't negate the presence of specific mental health and neurodevelopmental difficulties. It's getting that balance and not dismissing some of the ways that young people in care might be presenting as, oh, well, that's understandable given their background. So we don't want to miss specific mental health or neurodevelopmental difficulties that are there. This became increasingly apparent as we were developing the document as well, is that the presence of complex or multiple needs doesn't mean evidence-based approaches for specific mental health and neurodevelopmental difficulties will be ineffective. So there's something here about not excluding young people in care from mainstream treatments or interventions or therapies just by nature of the fact that they're in care. And there's some quite interesting conversations had with colleagues over recent years about external and internal stability. So there are absolutely situations and circumstances where the external stability around a young person is going to be critical to making any impact on their mental health and emotional well-being. But there are equally some young people where that may be very, very difficult and take a very long time to achieve. But there may be some things that we can do to help support internal stability whilst that external stability is being worked on. And actually, sometimes having a bit more internal stability can have a knock-on effect in terms of external stability, in terms of how they're presenting. So it's balancing those two against each other. So this is part of where we got to with our thinking is that there may be complex or multiple needs, but what we might be talking about is rather than a complex intervention or an overcomplicated intervention, we might be talking about packages of support that are multi-component. And of course, we might need to consider the sequencing and pacing of the different components of that. And we might need to consider adaptations or augmentations for the specific young person and their circumstances. But what I would say with that is that's no different from any other young person who we see in our mental health services. There are people who are not in care, who have multiple needs, who have complex contexts that they're living in. So this is something that we would be doing as a standard part of our practice anyway. This felt an important point as well. So attachment-focused support and support for specific mental health difficulties aren't either or. So there is evidence that attachment-focused support can improve mental health, but it might not negate the need for specific mental health intervention. So PTSD might be a case in point here. So there is evidence that even with attachment-focused support, PTSD symptoms may well not improve without a trauma-focused, a specific PTSD-focused intervention. And equally, the recommendations are that mental health interventions include caregivers, particularly for children in care, and that can improve carer sensitivity and strengthen the placement security, but it still might not negate the need for specific attachment-focused interventions. So I think really where that brings us to is that our offer of what's available to children and young people in supporting their mental health and emotional well-being should include both of those options, both of those possibilities. The importance of a psychological understanding or formulation of strengths, difficulties and needs is something else that we've emphasised. So there's a few bits here that I've just added in for today, given the audience, and then I wanted to just give a couple of case examples to finish up. So our section on attachment-focused interventions, one of the things I just wanted to pull out, because I'm aware that sometimes there can be a well-intentioned drive for individual therapy for young people to address attachment difficulties. And from all of the documents that we were reviewing, the conclusion was that individual therapy, including creative therapies, is of uncertain value. What the recommendations are is that for parenting programs, video feedback or dyadic interventions, so things like dyadic developmental psychotherapy, theraplay, those kind of interventions, that they are the most impactful and effective interventions in terms of attachment. And one of the things that we pulled out is that may still be possible in residential settings, but adapted to a professional carer if we can find one or two key practitioners in those settings who can be an attachment figure for the young person. Now, these interventions might not be possible for other young people in care, such as unaccompanied asylum-seeking children, but there are a range of other interventions that might be effective in developing their emotional regulation and interpersonal skills. So we have things like cognitive analytic therapy, dialectical behaviour therapy, interpersonal therapy, trauma-focused CBT for complex trauma, which would include some of those components within them. We've put a section on in around diagnosis, and there's an absolutely understandable fear of locating the problem in the young person, which of course we don't want to do. We want to view the problem in its context. And equally, as I said earlier, often, you might hear clinicians or practitioners saying, well, that presentation's absolutely normal and understandable. But sometimes that can risk leading to underdiagnosing or an under-recognition of mental health or neurodevelopmental issues that would benefit from specific treatments or specific interventions. So we've kind of recognised that in the document. We've recognised that diagnosis can be really, really helpful for some young people and much less helpful for others. So it isn't a one-size-fits-all. And we've also emphasised it's really important, even when diagnosis is happening, that it occurs in the context of a wider formulation and understanding of need, including some of those systemic influences. And similarly with medication, so there's a section on medication, and it's taken a similar stance really, which is that medication should be offered in the same way as it would be offered to children and young people who are not in care. So back to that kind of non-othering idea. So I just want to finish up by giving a couple of case examples, and then I'll zip it and we can open up to questions, and then we'll move into the reflection section of this afternoon. So the first one's an example actually from low intensity training. So this was a children's wellbeing practitioner style training at the University of Sussex. And there was someone who came onto the training who worked in a looked after children team over in Dorset. And there were some real mixed feelings in the system in Dorset about whether this was going to be an appropriate training for that practitioner. They were from a family support worker background, incredibly experienced family support worker, doing some brilliant work in the looked after children team already. And so they learned low intensity cognitive behavioural interventions. One of the young people they saw within the year was a primary age child who had significant anxiety around injections. And this was creating some major issues because they needed dental treatment because of their background and the context that they'd come from. They'd had poor dental care, so they really needed this dental treatment. It was going to have quite long-term implications if not. So quite carefully assessed the young person, explored whether there were any elements of PTSD in there, because obviously if it's PTSD it would need a slightly different intervention, and concluded that there wasn't. And so she went ahead and just delivered a short course of graded exposure, which would be your treatment of choice for a phobia. Lots of caregiver involvement, foster care involvement, and the intervention was incredibly effective. So by the end of the intervention, which was less than, I think it was 8 sessions in total, this young person was able to have the dental treatment that she needed. The dentist said that she was then set for life in terms of dental hygiene, dental health. The caregivers reported that there was a ripple effect from her being able to overcome this fear of needles and injections, where she was more confident and happier. Their sensitivity towards her was greater. Their relationship developed through the intervention, and they were describing that the placement was much more stable. So although on the surface, I think this is a really nice example where we might write off low intensity interventions or say this is a young person in care, it's far too complex, there's a much bigger context here. Very straightforward intervention, massive impact. Similarly, I used to supervise a clinical psychologist and looked after children's team within the Hampshire region, and they were working with a young person, and the young person was really quite down, quite low. And they delivered, alongside other work that they were doing consultation to the system, they delivered a piece of behavioural activation, which, as many of you will probably know, is a cognitive behavioural approach to low mood and depression that very basically looks at things that you can build into your week that give you some positive reinforcement, a sense of enjoyment, a sense of closeness or connectedness, a sense of value, and looking at cycles that you get into at times that you feel down that might be counterproductive, and how you might disrupt those cycles and replace some of those behaviours with alternatives that have a more beneficial long-term impact on your mood. So fairly, on the surface, a fairly straightforward intervention, but again, incredibly impactful to this young person. The nice thing about behavioural activation is that it acknowledges the life events that have led to you being low, and it absolutely empathises and validates those, but also recognises that there may not be much that we can do to change those events, but what we can look at is how we can improve our life in the here and now. So again, very impactful in terms of the mental health outcomes for that young person. And the final one I just wanted to mention is a piece of work that I did with a child in foster care when I was in Hampshire camps, where we did some trauma-focused CBT. And one of the things I tried to emphasise in the document around things like CBT is that it can be incredibly creative and flexible in its delivery. And I think sometimes that's not well understood out in the system, which might lead to it being dismissed as an option for some of these children. So we did a piece of trauma-focused CBT where we built on some of the life story work that this young person had and created a PowerPoint of her life and of some of the key traumas that she'd experienced that had led her coming into care. And through that was able to re-script some of her thoughts or beliefs in relation to those traumas and her role in them and her responsibility in them. And then as part of this PowerPoint, looking forward to that was what happened. This is the background. This is what happened. This is how I felt about it at the time. This is what I now know about it. And this is what my future could hold. So it kind of puts it in a timeline and gives a sense of hope and gives a sense of freeing up of how those memories or images affected the young person. And at the end of that piece of work, we agreed together that she really wanted to share it with her social worker and with her foster carers. So we had a session together where she presented this back to her foster carer and social workers as a way of helping them to understand her and where she'd come from and some of the things she'd been through, but where she was at with it now. And again, I mean, that was probably it was incredibly moving, powerful session, but the impact that had on her relationship with her social worker and her foster carers was enormous, alongside the impact that it had on her PTSD symptoms. So I'm going to stop there. I'm going to step down off of my slight soapbox that I can get onto with these things. I hope that's been a helpful overview of the guide and given you a bit of a flavour of some of the things that are in there.
Brilliant, Gavin. Thank you so much. I can see that we've got some questions. Geetha, would you like to take us through some of the points that are coming through the chat?
Sure. I'm just trying to get my...
I start us off with one, Geetha, while you find the chat. So Suzanne's made we'll do them in reverse order. Suzanne's made a really interesting point about the value of creative therapies and that kind of sense of not having to verbalise. I think, Suzanne, do you want to say what you were thinking and verbalise the question for Gavin?
Yeah, I'm just curious, Gavin, because I work in services where we use a lot of that, and of particularly high end. It's a multi-agency service that is commissioned to prevent Tier 4, but works with a lot of very complex looked after children. And we found that the most beneficial therapy for those is art therapy and drama therapy, which we use. So I guess I'm just curious about that bit of research that you came back with. I do know for a fact most art therapists are not very good at doing random control trials, and they aren't particularly engaged. And my cynical head would say psychologists are, so they will be more inclined to do that bit of work. You know, a lot of our team have had trauma-focused CBT training and will use an eclectic approach. And I guess I was curious about your last example when you talked about a PowerPoint, is that's a very visual way of a young person communicating. So yeah, I just wanted to challenge that, actually, if that's all right.
Yeah, Suzanne, so I can give you some context in terms of where those conclusions came from. And I think it's important to say that the statement in the document replicates a statement. Well, I'll say where it comes from first, and then I'll say the statement that we've replicated. So this was from the NICE guidelines on attachment. So I don't know if I'm sure a lot of people on the call will probably be really familiar with them. So there was a really extensive report that sat behind the NICE guidelines on attachment, which was completed by the Collaborating Centre for Mental Health. So if you go on the NICE website and you look up the NICE guidelines for attachment, there's a page that gives you the resources or the supplementary materials that they based it on. So this was I think about a 700-page report from the Collaborating Centre for Mental Health that was supported by the British Psychological Society, Royal College of Psychiatry, where they went through the research with a fine-tooth comb to look at what evidence there was for different types of interventions. And the NICE guidelines themselves then were put together as all NICE guidelines are, with a committee that included care leavers and included caregivers of care leavers as well. So it was so that's where the context for that element of the guide came from. I think what the wording is in the Collaborating Centre for Mental Health report that we've replicated in the guide is saying that it's not saying they're ineffective, but it's saying that there's limited evidence for their effectiveness. So I think that we need to be careful that we don't conflate those two things. So we're not saying they're ineffective.
Okay, because I think that's the challenge, isn't it? Because we're talking very much more about evidence-based, but what we're recognising evidence-based comes in lots of different ways. And if we're talking about, obviously, quite rightly, we should be having a very different multi-agency approach that isn't just clinically led to respond to young people. You know, we know about personal health budgets for young people, particularly that are looked after, that actually will choose to go to the gym every week because they find that more, you know, impactful than something else. So I just wanted to, it was just because of that bit, sort of slightly. Anyway, that's
yeah. And as I say, Suzanne, I think it's a really important distinction between saying something's ineffective to saying there's mixed evidence on how effective it is, and it's the latter rather than the former.
Yeah, thank you.
And I think then that some of that comes into that decision making, doesn't it, with the young person and the family about, well, there's mixed evidence for this, or there's not much evidence for this. It's not saying it's ineffective, but there's quite a lot of evidence for this, but it might not be for you. So what are your choices? Yeah. And I think the other bit, that was why I put the trauma focused CBT example in there as well, is also recognizing that some of the more mainstream therapies can be delivered in incredibly creative and flexible ways. So PowerPoint was one example. I've done scrapbooking with people, or collages, so there's lots of different ways that you can employ creative means to elicit or express and do those pieces of work.
Yeah, I agree, but I think we have to be really careful about our workforce, and we all know, and I'm sure it's the same for everybody in the Southeast, it is very hard to get specific clinicians in there, and actually we just need to be careful about how we focus those clinicians, that it's not just about having millions of psychologists necessarily. You know, I think we have to be resourceful, don't we, now, in terms of just how we recruit and to support. I'll leave it because I'm sure there's lots of other people with questions. Thank you.
Thank you, Suzanne. Geetha.
Thank you, Andrea. I'm just kind of an extension to the point you made earlier. Evidence-based practice, and I think that was a fantastic point you made in terms of explaining what you meant in your slide with evidence-based practice. It's really driven by academic research, isn't it, Gavin? It's about taking into account the practical experiences of people, both the therapists and the service users. And I think when we talk about the effectiveness of any particular modality of treatment, we're talking more in relativity, one against the other, and also based on the availability of resources in any given service. You might have a service where you have more psychologists and no art therapists, whereas another service where you have more art therapists and less of psychologists. So we've got to get that balance right. So a lot of factors contribute to it. And also my experience is that when you put a lot of input into just looking at the child, I have had a couple, I wouldn't say a lot of children who are in care, to say that, why am I being dragged to see people? So almost we're giving them an impression that you are the problem, let's sort you out. So we can't really independently address that problem without addressing the system. So it involves more than, it's way beyond just seeing the child, isn't it? So I think, and then again, it's about, I think you made a really good point about the consultations, how important they are. But again, we've got issues with the system where, for example, I can comment on mental health services when a child is open but not having direct face-to-face contacts with clinician. you are questioned. Why is this person open to the service?
That's a really good point, Geetha, isn't it? It links so neatly to some of what Hayden's put in the chat, actually. So I wonder if we might link these two things together, Gavin. Hayden's kind of saying, actually, the potential then for mental health clinical leads to be working through the team around this child. So we want to, it might be Hayden wants to comment on that a little bit. It's well established in Portsmouth, but that's a key point, isn't it? Hayden, did you want to say anything? And then
no, I mean, I'm just a massive fan of it, really. I mean, I think, as you well know, Andrea, and just say to other colleagues, our CAM service, we've got a very strong CAM service in Portsmouth, run by Solar NHS. But you'll find CAMS workers dotted around the system, particularly working alongside and hand in glove with children's social care, and not only around looked after children. And we frequently use that model because, some of our children have, we do push our kids sometimes to try and have relationships with multiple professionals. I'm not even sure if I could handle some of the kind of multiple relationships that we expect some of our children to have. And the more we can do, the more I'm quite a big fan of the kind of notion of normalising the child, the life of a looked after child as far as you possibly can, and investing in a smaller number of relationships, so particularly with the carers and the social worker, of course, but continually throwing more and more individuals and professionals at children is not really necessarily the way forward. Obviously, sometimes it's required, and sometimes children will require intensive support and treatment. I really get that, but the team around the worker model really kind of works for us and our children. A lot of our social workers want to feel held by a CAMS professional, and I think that's really good and really important. And so, because people are often scared of getting it wrong around mental health, aren't they? And I think by having a CAMS professional in that team around the worker, I think that is enormously reassuring and encouraging and enabling for social workers and indeed for carers. And our CAMS colleagues in the LAC service do a lot of work with our carers around placement stability, for example. And that's really, really key. So, and the other thing that drives it, Geetha, is around the madness that is how we measure mental health services by access rates, which is completely potty. I would say that because we're slightly below average, but actually just counting bums on seats in front of clinicians isn't necessarily the way of understanding the impact of mental health services.
Absolutely, and that co-working, isn't it, Hayden? And it's important that we join meetings really to understand the perspective of the other discipline. Yeah. And I often hear in meetings where, and that's what we train our juniors, whether it is a medical discipline or the MDT, to say when you're in meetings, all you need to say is that what is within your remit to support this child, young person, and the family, not that you don't want to do something. That's a very negative voice. And each one of the agencies sitting there needs to come forward and put on the table what is within their remit. And I think sometimes the huge risk is that the system replicates the disintegration in the child's family. They already have experience in real life, and we just replicate that in terms of the system around them, which is just horrible. And that's where the trust goes. Yeah,
couldn't agree more.
So, Gavin, go on, you respond to those points.
Yeah, no, I absolutely agree with what both of you are saying, and those three case examples at the end all happened with as part of a wider multi-component package, which included consultation and support to the caregivers. I think it's very, I get the impression it's very mixed still how consultation is received or perceived within local systems, and in some it seems like it's very well valued and recognised as useful, whereas others it's not. And I suppose some of this also just comes back to simple maths for me. So if you can see someone for 1 hour a week, a young person for 1 hour a week, out of however many hours there are in a week, can't do the maths right now, but do you invest the energies in trying to get a young person to comply, often not even consent, but to comply with coming along to see someone for 1 hour a week or 2 hours a week? Or are you better off investing that energy upskilling the people that are there all the time for them, or far more regularly?
Thank you, Gavin. That's really, and that links very nicely. No, please don't say sorry. This is absolutely why we're here together in community talking about it, isn't it? Deborah Page, Deborah, you've made some really excellent points in the chat too, and that links very much to, I think, your second point where you're saying, I don't know if you want to comment on this, Deborah, where in the case example, Gavin, you're recognising the need for integrative approaches that may pull on different models to provide what then becomes a bespoke intervention, Deborah, for the child, but then evidencing that is actually quite tricky. Do you want to say any more on that?
I mean, I felt quite anxious at the beginning of the presentation and felt really reassured by the end of the presentation about the recognition of the complexity. Because often something will come out from NICE and it's like, oh, that's not really pulling together the whole picture of how everything needs to work together. The 24/7 care the kids are getting, the support the social workers are getting, and their thinking and stopping the disintegration that Keith was talking about. So it is so hard then to evidence it, because if this bit starts going wonky, a really good intervention may not have the impact that it could have if everything's working together. That's all. Everyone knows that, but I don't know what we do about that. Gavin, do you know?
No. And I wouldn't pretend to have all the answers here. I was just thinking in terms of that, and again, going back to the example of the trauma-focused CBT. So I'm just sort of reflecting back on that piece of work. So I had training in dyadic developmental psychotherapy at the time. So I know that I was drawing on some of those principles in the way I was relating to the young person, but I would say that all that did was just ramp up the interpersonal skills I would be using in CBT anyway. The delivery of the actual piece of work, although I was trying to deliver it in a creative way, in a way that worked for the young person, it would still have shown fidelity to CBT. So if you had someone coming in with a purist CBT hat, they still would have been able to say, yes, this is a piece of trauma-focused CBT. However, would it have been effective without that wider package? Probably not.
No,
and that's the bit that I think is really hard to evidence, is actually what's the context that this work needs to happen in for it to be effective.
I agree, and I think saying just ramping up the sort of connection or the attunement through your DDP skills, I mean, that's kind of core for kids who mistrust relationships. So yeah, it's complicated. Thank you.
Thank you, Deborah. I can see that Sarah from Sussex is also contributing a sense of, you know, the importance of being trauma informed and understanding what's happening within the system that's either further traumatizing or reinforcing, creating some of these difficulties. I don't know, Sarah, if you want to just talk about that briefly. Yeah, Sarah, hi. We can't hear you, Sarah.
Classic faux pas. Since we introduced this in Hampshire CAMHS and working across with Children's Services, a trauma-informed approach, it gave people a kind of framework of understanding across agencies. We kept it really simple. And where's the child out on the triangle? Are they feeling safe? Are they able to make relationships? To try and get a common kind of sense of where these child's needs are at as well. But I guess I was running a trauma care group, DDP one this morning, and all the issues there were being created in the system. The child's behaviour was actually a manifestation of what the system's structure was doing to them in terms of placements and stuff. And I was merrily emailing away to social workers during it going, please understand this child's behaviour around he doesn't understand why he can't go home now, immediately, when actually a foster placement could be a breakdown and he could be moved tomorrow. So why can't he go back home in the same timescale? And his behaviour became incredibly risky. And I think the systems really need to understand what's behind the child's presentation, that it's not mental health, or we get a lot of the wrong types of referrals into CAMHS. So we're often doing a lot of just trying to sort the mess out, really, rather than maybe some of the purest kind of more mental health interventions. And I guess from Hampshire's point of view, we've got a modernising placements programme going on from Children's Services, but it's trying to get everything fitting together. And I think CAMHS tend to plug the gap while some of the other bits are happening, really. But mainly, which I think the main bit we find in the children in care team is we're advocating for the children's behaviour to be understood as it's distress. It's distress. I think the language needs to be, like you said in the document, needs to be in all our documents of difference around this is not a behaviour problem, this is distress. It's a trauma presentation, really, as we all know, and it's for people, when people understand that, then they do change their approach. But we've got a lot of work to do in terms of understanding it's not something wrong with a child, it's a normal reaction to what they've experienced, really, and are continue to experience in their care settings often, actually, in terms of people's responses to them.
So Sarah, that's so important. I'm wondering whether some of the points that are coming up in the chat link to this. So Geeta, I'm thinking about the points about where we see social care and CAMS colleagues sitting side by side together. And we've got some really excellent examples of that in the South East. I can see people say, oh, can we share that? Because lots of people want to move that way. Does that help? I can see Nicola from Oxford Health saying, you know, the AMBIT model, that's our new approach in Buckinghamshire to try and get this kind of shared understanding. So Geeta, was there anything you wanted to say on that, and Gavin?
I was just kind of following up on what Sarah was saying. I was thinking
Geeta, I think we may have lost your connection slightly. Geeta, I think we may have lost you ever so slightly.
I'm relieved it wasn't my connection there, Andrea. I was sat here thinking, oh no, my Wi-Fi is playing up again.
You could
Could
see
may I just come in on Sarah's? Like Sarah, completely agree with what you're saying, and you know, we've really emphasised that in the document about behaviour and looking beyond behaviour. And I suppose the other bit that comes hand in hand with that also is not just writing behaviour offers. Oh, well, that's completely understandable. Of course, they're going to behave like that. So actually being interested and unpicking what's behind it.
And I guess then the kind of mentalising approach, as Anna Foy described it often, that sense of a child and young person being able to describe what it feels like, looking through their eyes at the world becomes so important, doesn't it? Yeah, that's so helpful. We've temporarily lost Geeta, and I'm really mindful that our colleague from the Isle of Wight, Andrea Burrow, you kind of appeared and then disappeared, so I didn't know if you wanted to say anything. Geeta, are you back?
I am back, Andrea, but can you hear me now?
We can hear you, yeah.
It's been doing this all day yesterday too. I have to keep coming out and rejoining again. I don't know where I was, what I was doing.
You were just, we lost you really early on, so maybe start from the beginning.
Okay, just following on from what Sarah said, it's a double-edged sword, really. Not all looked after children, all their problems are not because they are having a traumatic background. They do have mental illness, and equally, not everything that they present with should be a mental illness just because they looked after children. And as much as we want them to be considered inclusive and not differentiate them from the general young people, the more we say the children in care and care leavers and all those terminologies make them stand out even more. And I don't know how we would address that issue and whether there is any literature to talk about how do we support these young people without putting them into that separate pot. Is that even possible?
Gavin, did you want to reply on that?
I mean, it's another, just thinking, it's another principle we could have built in, which is child first. They're a child first.
Mm-hmm.
And I'm interested by the terminology. I mean, looked after children used to be the phrase. I know that's still referred, a lot of teams are referred to as LAC teams or LAC therapists, but then we talk about children and young people in care, so we've shoved the children and young people bit at the front of it. But yeah, I don't know.
Also we need to be mindful of the support that young people need to be offered is not diagnostic led, because I often get the obstacle is that they don't have a diagnosis, therefore no support can be offered from school. And that becomes very difficult. So you're literally forced to give them a diagnosis just because that's the only way to get them the support. And that shouldn't be the case. It should be needs led.
Yeah. And that's one of the big systems changes that we need to embark on together. So where is this child? My colleague Trish Hagan and the LDA team is the expert at describing this really clearly. What is it this child needs? How then are we going to work together to create this? What we'll do, colleagues, is we'll move on to some of those reflective questions that we thought we might think about together, if that's okay with everyone. Because it was such a rich conversation. Anna Maria, I don't know if you could just bring up for us, please, the slide that's got the reflective questions on it. Thank you so much, that's brilliant. And so, Gavin, do you want to talk colleagues through these questions? And then colleagues, please do contribute by raising your hand or posting in the chat, whatever's more comfortable for you.
I think we've probably come on to some of them already, but there are others that might be really useful to hone in on. So these were just ideas of questions to guide some reflection. So first one was just how the guide fits with existing practice or service delivery. Is any of the content new or different? It feels like we probably have already had some conversation in relation to that one. So perhaps we focus on the other four. So next question was, how might the review or guide be useful in your clinical lead roles or your own clinical practice? So perhaps we start off with that. I'm thinking we have 20 minutes, Andrea, I think. So we've probably got 5 minutes per question just to, and please do use the chat bar as well. I think it's useful when we've got an audience this size to reflect verbally and non-verbally.
As a non-CAMS clinician in the room, I'd really appreciate the clinical view from each of you on how would you use this kind of information, so the bits of it that are helpful to you in your roles day to day. How do you see that working? Hayden.
I just can't bear silence, Andrea. Possibly just coming back a tad, because it's kind of building on the consultation point that we kind of had a really good discussion about. I don't think we've quite landed particularly on residential care today. So some of the and group-based living for youngsters brings its own interesting challenges for any of you that have ever worked in a residential setting. Because the work that you mentioned earlier, Andrew, that we're doing between West Sussex, Portsmouth and Kent is largely going to end up with a co-commissioned residential provider. And I think most of you will probably be aware that some of the residential provision that's in the private sector is possibly not the best quality and certainly not the best pound we spend on children. And the quality of mental health support or emotional welfare support in some of those providers is interesting. Let's just leave it at that. I'm kind of interested in the clinical guide in terms of what it says around supporting workers in residential settings.
Fascinating question. Gavin and Geetha, any comments on that?
Sorry, Andy, my volume just went. I couldn't hear.
Okay, I'll reframe the question, no problem. So Hayden's asking a really important question, which is, if we are fundamentally going to change our approach to residential provision for these children, how does the guide help us to do that with the individuals that we have both working in those settings and supervising and managing those settings too?
Do you want to start, Gavin?
I can do, yeah. I mean, we haven't majored on residential care, Hayden. If you've had a look at the document, you probably picked up on that already. But I suppose there's a couple of bits that might refer back to. So the core overarching principles, absolutely, and that might guide some of those mindsets towards the support of young people in residential care. Some of the bits we've already picked up on, but I think the wellbeing and resilience bit, again, I think that's so easy to overlook, perhaps even more so in residential settings, the importance of that element and the value that element can have. I think probably the section around attachment focused interventions, although it doesn't go into lots of detail about residential settings, that some of those ideas about supporting the adults around the young person. And I'm thinking, we've got the Secure Stairs programme that's been rolled out in Kent. I know some units have all trained up in DDP or AMBIT or some of the other approaches that we're hearing about in the discussion bar. I think that would be wholly consistent with what the guide's suggesting.
I think that's really helpful, and I really like the fact that it's got a section which is about that kind of early kind of emotional welfare bit. I do think group-based living gives it its own particular challenges, and I'm quite fond of the kind of concept of a psychologically informed environment. I think we need to unpick that because it's a notion that's kind of come out of adult residential, and I think it's something that needs unpicking and understanding better for children's residential. And without disrespecting some marvellous colleagues of mine, they're not the highest paid workforce in the children's workforce. Colleagues that work in residential, even less so in some of the private providers where colleagues are paid at minimum wage. You know, we get the same thing in some of our supported lodgings for some of our care leavers and homeless 16, 17-year-olds. So it's the transferability to colleagues that can be very new to the children's workforce on some of these ways of working with children and some of the understanding around trauma and the impact of trauma on behaviour, as we just rehearsed, and what are the kind of the safe support and interventions that you can give while supported by a clinical professional. I think that needs pulling out, I think, in future conversations.
I think, Hayden, the other bit that absolutely links to what you were just saying is one of the things that is emphasised at repeated points in the document is around psychological formulation, you know, whatever modality or theoretical perspective that's coming from.
Yeah, we need to keep reminding ourselves that 99.9% of the child's time is not spent in front of a clinician. So it's the impact that we can make on those around that child's life that is most important.
Yeah. So some really good examples of the kind of training for residential colleagues, and also in the chat, but also the kind of importance of the Thrive thinking, which applies both, Hayden, to the point you're making in terms of those children in residential environments, but it also applies to how we run our mental health services, doesn't it? How are we designing those services? How accessible are they for our children in care? So a return to the point of do not attend. Many of our children in care find it really, really, really hard to have that first contact with our services. So I wonder how this helps us with that too. Gavin.
Yeah, no, there was just something else I was going to add in here around there is something that we talk about in the document in relation to sometimes the caregivers might benefit from their own mental health and emotional wellbeing support. And again, I think that's equally as applicable, if not more so, to residential workers, just picking up on Hayden's comment.
Keitha, were you going to say something there as well?
No, I was just reflecting on the residential care, how I just feel the residential placements, it is very, very difficult to get our young people into residential placements, especially those who have had multiple foster care breakdowns. But it appears like that residential placements give more stability. They've got that relatively more permanent in terms of their rules, their lifestyle in a residential care, as opposed to where they're placed in, when I say unskilled foster carers, they don't know the needs of the child before they take them on, and then they can't cope. The placement breaks down, so there's another rejection. So there's a sequence of rejections when they are placed in inappropriate placements. So really, I would hope that in future we have more therapeutic residential placements for children in care, especially the adolescent group.
Yeah, thank you so much. We've got some other really helpful points. Peter, thank you so much for the offer about secure stairs. And I know that we've already given you a little tap on the shoulder and said on the 5th of July, when we all meet together, Hayden, don't we, to look at this co-commissioning, please, can we talk about this? So that's certainly one opportunity, and there are others too. Gavin, do you want to say anything more about Kim Goldie's pyramid of need in relation to some of this? I can see that you've popped that in the chat.
Just it's just another tool or framework that you can use to aid discussions around what level or what type of intervention you might be looking at, and again just has the individual therapy or mourning, trauma and losses right at the very top of the pyramid. So this idea of it just supports exactly what we're talking about here, about that consultation and that support for the adults around the young person, but in visual form. So it's quite easily accessible on the internet for those that haven't seen it.
Okay, so why don't we move on and consider another question, Gavin?
Yeah, one thing I'm really keen that we don't lose time for is the very last question, because I think that helps us to pave the way for our next webinar, which, as we said earlier, is with commissioners and service directors. So perhaps we can skip on to that and then we can come back to some of the others if we have time.
Yeah, I've just seen Asha's hand as well. Sorry, Asha, I don't know if I missed you. I've just seen your hand. Did you want to say something?
I just wanted to actually mention something. One of the issues that I find is that we talk about carers being able to support these young people who have significant needs and have experienced trauma. But without supporting the carers, sometimes without the carers actually having access to respite or other kind of basic needs being met, I can only imagine that it becomes overwhelming for the carers, who then actually feel that they can't actually do anything anymore, so they give up, which then feeds into the rejection cycle for the young person. The long-term carers, even the skilled ones, it is really hard sometimes. And I wonder what sort of resources are there for these carers in terms of having regular respite support or their basic needs being met. It might be employment or childcare or something else.
Yeah, crucial question, Asha. Thank you, Gavin.
Yeah, I was just going to come back on what Asha's comment. I think it's really useful. One of the things that was quite interesting when reviewing some of the documents and guidance already out there was that there was a specific reference to respite and that it can be really useful. And I don't know whether things have shifted, but historically, when I've worked with some social care teams, there's been a real resistance to putting respite in place because they see that as a step towards a placement disruption. And actually, it was quite good to see in the guidelines that it was saying there is evidence that it can be really effective and it can really help because it gives the carers a chance to recharge. And the other bit, I mean, it's always fascinating, the kind of mismatch between what's recommended in some of these guidelines and what actually is available or possible in practice. But I'm just thinking back to the earlier comment as well, that there were recommendations in the attachment guidelines around intensive training for foster carers before a child's placed with them, that then continues for a year post-placement. And I'm just curious, like, how, in reality, how often does that happen and what capacity is there in the system for that?
Yeah, that's really important, Gavin, how much theoretically we can make wonderful recommendations, but in practice, how much of that is really happening or can happen?
So colleagues here in Kent and Medway, we were together this morning, weren't we, in ICS specific conversation, and some of what we were talking about is what's possible with social care leaders around trying to then support a whole range of complex children, actually, including children in care, but not limited to children in care, in a range of settings that these children sit. How can we support caregivers to sustain that? What are the options and how can we design that? So the gap between where we want to be and where we are is quite real for most of us. There's a whole range of other points coming up in the chat. Sorry, Hayden, did you want to comment on that?
No, I think it's very interesting. So I've worked in the local authority and looked after children for many, many years. So the recruitment and retention of foster carers is an ongoing challenge, isn't it? It's always an ongoing challenge. And I've got to be careful how I word this. Sometimes people are approved into care and they are perfectly capable of looking after children with a certain profile, but not another profile. And the matching of the child to the carer is not always how we would like it to be. And that's a resource-based issue. So so you'll often get children with really quite complex needs with relatively inexperienced carers. I think local authorities have got a job to do, and I would say this, wouldn't I? I think we've got a job to do in really streamlining but hefting up the support that we give to carers, because I think we're moving away from this. Around just the kind of sheep dip training idea that there you go, we've supported foster carers because they've done 2 hours on something or other, and actually wrapping much more support around carers, including mental health expertise, I think is the way to go, because it is an investment. Because when those placements break down, apart from the damage to the children of yet another broken relationship, the financial cost can be ridiculously huge if we end up playing in external residential placements that we were talking about earlier, Andrea. So it is an investment, investing in carers, but I think that penny's only beginning to drop in local authorities in the last decade or so. I'm not sure it's always been there.
And there's some excellent suggestions in the chat here about how individual areas are responding to this and trying to resource this kind of support for carers and sustain it. Thank you, everybody. Asha, your hands up.
Yeah, just comment on what Hayden was saying. And the impact is not just loss, financial impact and the cost for that, but the cost of losing foster carers, experienced foster carers.
Yeah, absolutely. Absolutely, Asha.
I think if you don't have them, you're not going to actually support a big group of kids who are going to need them as well.
Absolutely. So thank you.
I think actually the pyramid that we were talking about, the pyramid of needs, Kim Golding's pyramid, I think I hope there is kind of similar things, thinking about pyramid of need for carers, what needs to be the basic needs that need to be met before they take kids on, and what's going to be at the top of that pyramid.
Yeah, absolutely. That's brilliant. Thank you, Asha. Gavin, you were trying to move us on to the last question, weren't we? And we got distracted. Come on.
That's okay. I know I was just going to pick up again on Hayden and Asha's comments. Just one of the things that I was mulling over when we were pulling the document together is that the training for foster carers and the support for foster carers, whether that's multi-agency, because it feels like there's some there's a risk that it gets in silos, and actually that crossover could really enhance how beneficial and effective it is.
I think it probably is. In most places it will be multidisciplinary and multi-agency. I'm not sure. It's whether we've moved to that more kind of, we all have that experience, haven't we, of shifting away from training into much more coaching, mentoring styles of learning and ways of learning, and whether we've kind of moved fully that way in terms of our support for carers, I think is a moot point.
I was just looking at David's point, David Morley from Surrey. You were just wanting to highlight the Surrey approach, this 12-week. Do you want to say any more about that? That looks really interesting. Don't mean to put you on the spot, David. Is that right? Have I just done that?
Yeah, it's actually one of the young people I'm working with has been staying there. But in Surrey, we have a service called Hope, and it's a day program, and it provides, well, it's for young people at risk of hospital admission and really struggling in school as well, and at risk of going into care or are in care and at risk of moving out of county. But there's a 12-week pilot to have a foster placement alongside the Hope program for young people who have kind of had lots of hospital admissions in recent weeks, because there's a huge struggle with placing children into stable placements, into locating foster care placements for teenagers. So yeah, that's kind of only a few weeks in, but going well. So the hope is it would expand a little bit more in the future.
Brilliant, David. Thank you so much. So again, Surrey Hope's model is one of the models we've got available to share with colleagues who are saying, can you share some good examples? So if you want to update that with us, just a few lines even, we'd really value that, David, if that's okay, with colleagues in the CCG as well. So just we've got a little bit of time left in terms of discussion time. Just wondering about your key messages back to both social care and health commissioners and service directors who will be certainly meeting with health economy commissioners and the directors in CAM services in a few weeks' time. What would you want to say, everybody?
Sorry, Andrea, I again lost. Can you repeat that, please? I couldn't hear. Oh, I'm really sorry.
No, not at all. So we meet with the directors of CAM services and also with commissioners in a few weeks' time. I was just inviting people to say, what are the key things they'd really like taken into that conversation around children in care?
Can I say something, Andrea? I would like to really add, I mean, just kind of picking up on all that my predecessors have spoken about, it's skilling up the workforce. I think there needs to be investment in really skilling the workforce who are working with these young people, whether they are in supported accommodation, residential schools, placements. And I was just responding to Sarah in the chat box that the so-called therapeutic placements, social care finds therapeutic placements which are nothing but therapeutic, anything but therapeutic, sorry. There's no therapeutic component to those placements, but then there is a financial component attached to it, and there's a compromise on that. So we as CAMS think, okay, you are in a therapeutic placement. So would it be fair to you seeing another therapist within CAMS, or there is an expectation? So that's sort of doubling up. And we need to really be very, very clear and transparent about that. And it really making education a center of this co-commissioning consideration. How does it, because education really is one factor that's going to normalize these young people's lives among all the abnormalities that have happened in their life. And somehow education can say, well, we can't cope with their behaviors and therefore they're going to be excluded. And to where?
Yes. So education has the potential to be one of the most protective characteristics and universal. Absolutely. Thank you.
So it's a co-commissioning. I would come back to that. And that would be my real emphasis on understanding how that would happen. What are the principles behind that going to be? And how do we spread that news and whatever else about co-commissioning?
That's brilliant. Thank you. I can see in the chat that we've got a range of suggestions around investment and joining up our coordinated commissioning approach. So that's a join up on two levels, really horizontally with the kind of CAMS education and mental health offers, and the integration, I think, is what most of us, if not all of us, are striving for. But also important points about 0 to 25, which links back to where we started with community mental health transformation as well, doesn't it? And young adults. So these are all key points that we'll take through. Suzanne, your hand is up.
Yeah, no, I was just going to say, I think so for example, in Surrey, I think we've got the most phenomenal ideas. I think we're commissioning really well. We're already trying to join up. I think what is frustrating at times is a slightly short-term view of trying to save money that in the long run becomes more expensive because of limited of resources, and I think that's what probably is the most frustrating. So and I don't know how people can move into a place where they are actually thinking of investment and feel like putting the money in the long term is going to actually save money, because you just see a reactive response most of the time when a number of things fail, and then you're moving them out of county, or and I think that's the challenge, to be honest.
Thank you, Suzanne. Deborah, you've also made a really important point. So that Suzanne, in terms of the preventative approach, absolutely. I don't know if anybody saw the NCB, National Children Bureau's evidence republished last night with the support of Cambridge University and various others, saying why on earth have we ended up in this response to austerity that's led us to a place where we've lost so much of our preventative offer. How can we get back? So please do look at that if you haven't seen it. Deborah, you're again picking up the similar workforce points to Geetha, but that kind of shared understanding across our statutory partner offers, and we would extend that, wouldn't we, to our voluntary sector and education too. Thank you so much. Okay, I've got Suzanne. Is that a new hand? I've got a hand showing Suzanne for you. No, okay, wonderful. All right. So what we might do now, colleagues, because I'm conscious that we've covered so much, is unless there are any other points that colleagues really wanted to share, we'll probably then move through to a bit of a sum up, if that's okay. And also next steps. It is beholden on us just to say, any support that you need, please do come back to us. And both Sam and James are here, and they've offered support with community mental health transformation thinking into adulthood. Sam and James, thank you so much. We really appreciate that. So, Geetha, over to you.
I just would like to thank you, Gavin, Andrea, and everybody who's attended today. It's been an honor to be here, and it's been such a pleasure. I think it's been such a rich conversation we have had, although it might seem that we've spoken about things that we have lived with in a long time in jobs that we are doing. Still, it's always, we need these constant reminders, constant updates on what has worked until now and what needs to change and what can stay the same. I think that's really, really important for us to periodically reflect on. And this has given us a forum to really bring those ideas together. And as you rightly said, Andrea and Gavin, that none of these are same across the country. Different areas have different systems in place, and it's all about learning from each other. And this has given an opportunity for that. And It's been such a pleasure. Thank you very much to everybody. And I know you've already collected what is that needs to be, that's real burning issues that could be taken to the next meeting in July that you want to emphasize. And I've mentioned my 3 points, and I wonder if the others would have anything to put in the chat box that could be, that you could take to the next meeting or further discussions with commissioners. That would be really helpful. And in terms of any issues with this co-working between social care and mental health, Andrea and Gavin, are there any contacts that if we are stuck with anything in any situation, is there a specific email that we could ping in just to get some clarification? So we are in this position. How do you think we can address this in a better way? Because what we're using now isn't working and we have no other solution.
Yeah, Geetha, that's a really good question. So colleagues will know that lots of those are kind of emails reach my inbox. So my email address is there. In terms of individual operational systems, please, colleagues, do ensure that you've gone through your local systems for resolution before anything finally comes to us for any support. But certainly in terms of the strategic questions and the design, don't ever hesitate to contact us. That's what we're there for. Yeah.
Thank you very much, Andrea. And Gavin, it was a fantastic clinical guide and I've read it all. And I said to you at the beginning, it was like just reading my day-to-day life practice. And you've captured everything that we actually experience in a day-to-day clinical practice.
A huge thanks, Gavin, on behalf of us all, because it was a huge amount of work for you, not just 2 pages of A4, as you keep reminding me.
But I think, as we said at the beginning, it absolutely, it's been co-produced. I mean, Lee from Cork and Anna Freud was absolutely brilliant in helping us, especially with the wording, making sure the wording was right, and all the content on screening tools and things. And I think all the other people that we've acknowledged, it wouldn't look the way it does without all of that input. So.
Wonderful. Colleagues, we will share this recording with you. Geetha, thank you so much for joining us as a clinical leader with investment and passion about this work. We really do appreciate it.
Absolute pleasure. Thank you very much. And for even thinking, and I know Jihad recommended,
yes,
but you took me on. Thank you very much.
You're so welcome. So colleagues, we'll send out the link and all the documentation. We wish you well for the rest of today and a period of rest as well over the weekend. Take care, everybody, and thanks for being with us today.
Thank you very much. Bye, everybody.